these joints exist in slightly movable forms in what are called syndesmotic or syndesmosis joints between the tibia, fibula, and the radius ulna. Syndesmosis. Nerves are named for these. Syndesmosis joints run through these unions between the tibia, fibula, radius ulna. Okay? So there's only one bone up here, but there's two down here. And there's only one bone up here, but there's two down there. And as it turns out, they are actually held together. The bones of your brachium and crura, the bones distal to your elbow, cubital fossa, and distal to your knee are held together by dense fibrous connective tissues. And those tissues actually help to form compartments. They form pathways for blood vessels and nerves. They're really important. But today you're learning that they are called syndesmotic joints. They are held together by fibrous connective tissues. And finally, gomphosis, which I mentioned briefly when talking about Sharpie's fibers before. Gomphosis are dentoalveolar joints. It is considered a joint where your tooth sits in the maxilla or mandible, a dentoalveolar joint. All right? Now, the details of these are not going to come. I've said all I'm going to say about sutural joints, and I'm not going to say anything more about the details of the nerves and blood vessels in the syndesmotic joints between these interosseous membranes between the bones of the arms and legs. This guy will come up again in the spring. And I'm going to say, I'm recalling that there are three kinds of joints. And you're going to say, fibrous, cartilaginous, and synovial. And I'm thinking to myself from the fall that the joints between the teeth and the bones are actually dentoalveolar. They're actually gomphosis joints, and there is fibrous connective tissue holding these things in place. Let's look at that and name them. Let's name these things, the dentoalveolar ligaments, etc., and the cementum and the dentin, and the stuff that holds that joint in place. It's not supposed to move. All right, once it's formed in the adult. All right, the second kind are the cartilaginous joints, and you've seen some of these already. We've talked about today. I showed you a fibrocartilaginous union in a synovial joint. As it turns out, there are places in your body where the fibrocartilage is between two bones and there's no joint cavity. It just sits between the bones. Can you think of a place where you've seen that? Yeah, between the vertebral bones. Now, I didn't show you the other one, but there's another important one in the human body. Does anybody know where it is? Where two bones join together. I mentioned it when I showed you fibrocartilage, just very briefly. I didn't show you a picture, but I mentioned it. Between the two pubic bones. So where they join anteriorly is a piece of fibrocartilage there. These are called cartilaginous joints. Now, they're not very movable, right? They don't slide around. So we say they're slightly movable as symphysis joints. And in other places, they're immovable. So the immovable joints tend to be made of hyaline cartilage. And we call these the synchondrosis joints and the costal cartilaginous joints. So don't get confused between a syndesmosis and a synchondrosis. How are you going to remember that? Chondrocytes make cartilage. Yes? So a synchondrosis is a cartilaginous joint. Now this suggests that there are immovable synchondrosis in your epiphyseal plates. Now tell me what you know about an epiphyseal plate. Is an epiphyseal plate in my body hyaline cartilage? In my body, are my epiphyseal plates hyaline cartilage? Where is the epiphyseal plate, young people? What is another name for the epiphyseal plate? As the bone is developing, there's a primary ossification center, and the bone starts working its way out, right? And then just a little while later, there's a secondary ossification center, and the bone works its way down. And between the two, at the epiphysis, is a piece of hyaline cartilage, which is what the fetal bone was, right? And so the game is on. Growth hormone, thyroid hormones, estrogen and progesterone and testosterone are all feeding the cartilage and the bone cells. And the growth is on through puberty, right? And then what happens? The bone from the primary ossification center catches the cartilage. And is there any cartilage remaining? There, you're right, on the ends. But in the plate, there's nothing left in the plate except bone, right? And so really, when you say it's immovable, I'm pointing this out because it helps people remember. When you say it's immovable as an epiphyseal plate, what you're saying is it's really not cartilage anymore. You see the problem with the description here? So yes, it is an immovable joint in the teenager. But in my body, I do not have a hyaline cartilage epiphyseal plate. This is bone development stuff. All right, and then the last one, we're going to see this one today. I'm going to talk about the pectoralis major if I can get there. The costal cartilages are the unions between the ribs and the sternum. Now, this is an important little piece of information here to help me teach ribs, which we've not talked a lot about, but I've mentioned it. The cartilaginous unions between the ribs and the sternum are hyaline cartilage. And I always use this at the beginning of the semester when I'm teaching cartilage types. And I tell the students, if you're going to do some procedure on the heart, you don't cut through the cartilage because cartilage is poorly vascularized. It doesn't heal well. Instead, you take a saw and you cut through the middle of the sternum to open up the thoracic, the mediastinum, to get to the heart, right? Okay, so as part of that, I like to give a little bit more anatomy. As it turns out, everyone has 12 pairs of ribs. Most people have 12 pairs of ribs. There are exceptions to this, but the vast majority of the human population have 12 pairs of ribs. And they're split normally into the true ribs and the false ribs. Now, as it turns out, the true ribs are called true because they have a direct connection, a hyaline cartilaginous connection to the sternum. So, hyaline cartilage, costal cartilage connection to the sternum for the first 7. Rib to sternum, rib to sternum, rib to sternum. If you now go to the 8th rib and you work your way toward the sternum, you can in fact get there. But the costal cartilage of the 8th rib actually connects to the costal cartilage of the 7th. And the costal cartilage of the 9th rib connects to the costal cartilage of the 8th. And the costal cartilage of the 10th rib connects to the costal cartilage of the 9th. Did y'all follow that? The next 3 are called false ribs because their costal cartilages do not connect directly to the sternum. They are fused to the cartilage above them. Now the last 2 pairs of ribs do not have a costal cartilage attachment to the sternum at all. And for that reason, they're called floating ribs. Did you just learn true and false ribs and floaters? Okay, so with respect to the costal cartilage connection. The last piece of this is synovial, and this is where we want to spend most of our time. Let's look at the examples. You name it. You can cheat. We started with fibrous, right? Dense fibrous connective tissue joints. This one is suture. The interosseous ligament. This one is. This says syndesmotic. What did the last slide say to you? A syndesmosis Two ways of describing it: syndesmotic or a syndesmosis joint, the interosseous ligament. How about this one? Gomphosis. This is the dentoalveolar joint, dense fibrous connective tissue. Cartilaginous joints. Fibrocartilage between the pubic bones, fibrocartilage between the bodies of the vertebral column. Synovial joints have several characteristics that we find in most of them. Characteristics of synovial joints. This is a knee. And we're going to do the knee when we get there. But I want to use this picture to teach you the components of a typical synovial joint. All right? The first thing is, if we follow this outline, you can see that there is soft tissue that outlines a cavity. So synovial joints have a cavity. You won't find one of these between the fibrocartilage and the vertebral bones or in the pubic bone. You won't find these in the sutural joints or in the jaws. There's a cavity here that is enclosed. And it has fluid in it. And the fluid in this cavity, the cavity we call a synovial cavity. Synovial joints have a synovial cavity, and they have fluid in them. And the fluid in that cavity is secreted into that cavity by way of the vascular supply to the lining. And that lining is called the synovial membrane. So there's an epithelial and connective tissue lining of each of these synovial cavities. And within that connective tissue that forms the synovial membranes are blood vessels that secrete fluid into the cavity. So you're supposed to have some fluid in here for lubrication. Now, if you damage a ligament, a tendon, or something in the synovial joint, or if you have, let's say you have rheumatoid arthritis that has been damaging the connections between the bones and causing deterioration, then any clinician worth their weight can stick a needle into one of these synovial cavities, like this one in the knee, and pull the fluid out and do an analysis on the fluid and make some kind of diagnostic conclusion about what's going on in the joint. One of the most simple diagnostic things is if you see blood cells in the joint. So if there's not been an athletic injury, then you know that there's deterioration of the bony ends in that synovial joint. If there's blood in there, you've damaged the synovial membranes. Okay, there's fluid, there's a cavity, there's synovial membranes. In addition to those pieces, synovial joints have bursa associated with them. Now that doesn't surprise you. There are a few shown here associated with the knee. There's at least 12 named bursa associated with the knee. I showed you 4 associated with the shoulder. That is a prototype of synovial joints. They have a synovial membrane. They have a synovial cavity filled with fluid. They have bursa associated with them. And the ends of the bones in the synovial joint tend to be covered with hyaline cartilage. So this is a knee, it's a prototype. The shoulder is a little different because you got a fibrocartilage pad in there. But this one would work there also because you got 2 fibrocartilage pads in here. The ends of the bones tend to articulate with each other by way of articular or hyaline cartilage. So these are the parts of a synovial joint. A cavity filled with fluid, a membrane, bursa, cartilage. These are the prototypical things that you find anywhere you go in the body with a movable joint. In your jaw, in the temporomandibular joint, in your shoulder, in your elbow, around the articulations of the carpals and the metacarpals, the carpals with each other. These are all synovial joints with individual joint cavities, individual articular cartilage and bursa and fluid, etc. Prototypes of synovial joints. Now, I didn't do this one before, but I always mention TMJ. Did y'all hear it? There. So I like to show students this. I promised it to you earlier. So I just look at the picture and then I have to do some gyrations in front of you. Okay, so this is a typical synovial joint. The articulation between the mandibular condyle of the mandible and the mandibular fossa of the temporal bone. And you can see that this joint, like the shoulder that we saw, has things that help hold it in place. I've got them numbered. So the big ligaments that hold this thing in place are right underneath your parotid gland. So if you pull the skin off of your face, there's a gland right there by your ear. It's a salivary gland. So you would have to pull the salivary gland aside in a cadaver dissection, and you would see those ligaments right there. They are the lateral ligaments of the temporomandibular joint. They're the most important ones, holding this joint in place. Now, the second one, you can see here, it's a bit less important, is called the stylomandibular, and the third spheno. Now, these two are attached to other pieces. The styloid process is part of the temporal bone that we talked about, and the sphenomandibular ligament is actually attached to the sphenoid bone of the skull and inside the mandible. That's supposed to be shaded. You wouldn't see that. It's on the other side. It's on the medial aspect of the mandible, holding it in place. Now, if I pull that off, if I cut the lateral ligament off and open the joint capsule, inside you would see that the joint itself has articular cartilage, joint cavities, synovial membranes, synovial fluid, the typical things that you expect to see. There's no bursa here, so it's an exception in that sense. But you can also see in this picture why so many people have trouble with this joint. The joint itself has an articular disc, a piece of fibrocartilage within it that separates the end of the mandibular condyle from the mandibular fossa. The problem in the joint is there's too much space on the anterior and posterior sides, and the muscular attachments, the way the muscles pull on this thing, actually cause it to hinge and slide. The hinge part is not normally the problem. If the joint would just hinge, there would probably not be an issue. But what happens is the joint actually moves forward as it hinges. The condyle slides. It slides on the articular disc. And if you are prone to gritting your teeth with tension, pressing that condyle into that articular disc, over time, you will wear it down. And if you wear that disc down, you will put articular cartilage on articular cartilage, and it won't be long before you'll be bone on bone. So we try to prevent these things for people because that's a lifelong problem once that happens, once you damage that cartilage. I want you to see the cavity, see the capsule, and see what it looks like. That is the temporomandibular joint. Now, joints move in a number of different ways. So, if we're going to describe joint movements, I've used a couple of these words with you already. I've used abduction and I've used shoulder flexion. Most people can come up with these motions by common sense. So what I'm going to do for the next 3 or 4 minutes is I'm going to try to illustrate these things for you up here, and I'm going to pause momentarily with each one of them that causes students problems. Okay, so this one doesn't create a problem. Examples of gliding motions. Flexion, extension, dorsiflexion, abduction, adduction, circumduction. Some of these do and some of them don't. So let's look at some of these together and let's illustrate them. Okay, first, gliding. This doesn't cause any confusion. They can see the gliding motion. That's fine. Flexion and extension pictures here are shown for places where it's obvious and places where it's not obvious. So I always make a point to mention the deltoid for shoulder flexion because once you've seen that, then you start to pick up this language. Now, if I do this, everybody says flexion extension. That's fine. You got that, right? If I do this, everybody sees flexion extension here. So no problem. Okay, but what if I do this and this? Yeah? It doesn't, so if I'm going to define it, right? If I'm going to define flexion as decreasing the angle of the joint, then that makes perfect sense here. And it makes perfect sense here. But if I call this flexion, the shoulder, what joint angle am I decreasing? Some imaginary joint here? This causes problems for students. So some people imagine this would be extension, but it's not. Extension is this way. This is flexion at the shoulder, this is extension at the shoulder. All right, so that's a confusion point. Here's another one. What about at the hip? Okay, so most of the time, if I asked you what this action is at the hip, students would say flexion, and you'd be right. On the other hand, if this is extension at the shoulder, then you would think, well, this will be extension at the hip. But that's not right, is it? Yeah, so in anatomical terms, the upright position, I am currently standing in reference to my hip in the extended position. If I move, if I angle posteriorly, I am now in the hyperextended position at the hip. Things that cause confusion. Same thing with the head. I get it. Flexion, extension. Is that right? That's not right. Flexion. I am now in the extended position with my head. To move it this way is to say I am hyperextending. Exactly. Okay. So normally students think hyperextension is not good. Why is that? If I hyperextend my knee, I will normally tear the anterior cruciate ligament. That's what normally happens. If I hyperextend at the elbow, I will tear multiple pieces of the annular ligaments in my elbow. And you probably break the olecranon in the process. So hyperextension we normally think of as bad. But at the hip and the head, it's normal. Okay? This one gets kids, all right? This flexion thing at the feet. So if I take my wrist and I do this, then you say flexion, right? And if I take my wrist and I do that, you say extension, right? You're right. Okay, let's do the foot. So I take my foot this way and I do this way. And you say flexion. Okay. How about that way? Extension. Okay. That's what I would do. In fact, that's the way the muscles are named. So when we get to the leg muscles, I'm going to point this out again. Okay, can the anatomists please make up their minds? Okay, so this is actually called dorsiflexion, the thing that you would call flexion. And the thing that you would call extension is not extension at the foot, at the ankle. It's called plantar flexion. All right. Abduction and adduction and circumduction. What's the difference here? Okay, so you got the AB and adduction, right? Because we did it with the deltoid, right? Abduction, deltoid. If I add the limb, add the extremity to the mass, I adduct. So, what is this? Abduction. What is this? Adduction. Abduction, adduction. Abduction, adduction. All right? Oh, circumduction. What's the difference then between circumduction and supination and pronation? So I have those here on the hands, right? We did this when I did the anatomical position. This is to supinate, anatomical position, supinate. This is to pronate. Supinate, pronate. Supinate, pronate. How is this not circumduction? Supinate. How would circumduction look different? Yeah. Okay, so circumduction is to create a cone. A point with a wide piece. Circumduction. Yes? I'm creating a cone. This is the point, and I'm making a cone. Circumduction that way. All right, I think I got them all. Rotation is never a problem. Inversion, eversion is never a problem. Retraction, protraction is not a problem. Okay, so next time together, remember before you come to class to take your quiz. It's going to be a big one. So major bonus opportunities coming in the next 2 days.